Oh, that's fantastic. It was lovely to see the little smiley faces. So all of the children there had two things in common. The first is that they were all extremely cute, obviously. And the second is that they all have a parent or a grandparent with CF. So they are absolutely the legacy of the future of the CF community. So it's lovely to see them. So we're moving towards our final session now. And this evening, this section is entitled Pregnancy, Parenting and Contraception in CF. And we have three lovely speakers lined up for you. I'm going to introduce them all to you first, and then we'll have them back in one by one. And like earlier with our research roundup, we'll have a Q&A section at the end. So please do continue to put any observations or comments or thoughts in the box, which would be great. We've over 70 people logged on this evening. Just to let you know, I think we had, in excess of that yesterday. So it's a fantastic turnout on both evenings. And I think we had some people from abroad logging in as well. So it's great that we are having just such a widespread and huge knowledge in our presentations that we're attracting an international audience. So moving into this section now, I'm going to welcome Dr. Jennifer Donnelly, who's a consultant at the Rotunda. I'm going to welcome Rory Tallon up next. And I'll introduce Rory. Rory is a person with CF. He's known to many of you as a member of the member services team at CFI. He's a dad, and he has two children in primary school, which is hard work in and alone of itself. So I'm going to invite Rory to present, and then following that, we've one more presentation before we move to Q&A. So please continue to send in questions if you have them. Thank you.
Hello. Okay, thanks, Patricia. That's a nice introduction. So thanks everyone. Welcome to this opportunity to speak about a really important aspect of CF, and that's parenting and the journey to become a parent. So Jen has spoken about her experience of pregnancy, and that's very important. That's a very important journey in CF and has to be managed very carefully. But the other aspect of having children with CF is being the parent as well. So I want to focus a little bit more on the parenting, but I will talk about my journey to become a parent and some of the considerations around that. So really, it's what I'm speaking about is really my aspects of my journey to be a parent on my CF, or aspects of my journey as a parent on my CF, and then aspects of my CF on that journey. So I will start to say that I don't necessarily have, this isn't a parent hacks lesson or seminar. I'm by no means a perfect parent. I would never even think to claim that, but the importance of this slot really is to reflect some of the findings that we found in our independent living survey, which we published in 2018. And in that survey, it was a survey to assess all the various major life challenges and issues, how CF impacted your life in college education, career, health challenges, and so on. And one of the findings that we introduced, or one of the things we introduced in that hadn't really been looked at before was, how many people with CF in Ireland are parents? And of those that responded to our survey, approximately a fifth of those were parents, which was quite an astonishing observation that we weren't really aware of previously. So that's why this slot here today is really important to highlight that this is becoming more of an aspiration, more of an event, and that there are challenges. And in males with CF, somewhere between 98 to 99% of males with CF are born infertile. So my journey starts when I first learned that fact. And the aspect of becoming, or the struggle or the aspiration to become a parent with CF, for a male is different than the challenges presented to a female with CF who wants to become a parent. So as I said, my journey started when I was 17, when I first was an inpatient in the adults CF Centre at St. Vincent's. And I remember distinctly during a physio session, the physio explained to me that males with CF were infertile, and that I could be tested for that, just have a simple sperm analysis. At that point in time, I took the decision that, well, it's not relevant to me at that point in time in my life, that I would revisit that analysis if and ever it ever became relevant to my life. So then the importance around this also is, regardless of whether you have that sperm analysis done at an earlier age, you know, when you first transition to an adult clinic or slightly later, what you need to know is you can't really assume infertility either. So just because you're told that fact, you can't assume it. You should have it confirmed. And in my case, I didn't have it confirmed until, as I said, I felt it was necessary to know that information. But at the same time, it is important, as I said, don't assume infertility. And in terms of sexual health and sexual, you know, habits and practice, you know, you do need to use contraception, not just from risk of pregnancy until you have infertility confirmed, but also in terms of sexual health and preventing sexual transmitted diseases and so on. So jump forward then 20 years from that point in time. You know, I met my wife, Sarah, when I was mid-30s. She was a little bit younger than that. And very quickly in our relationship, you know, I explained everything on the table about CF, the impacts of the condition on my life and my health, including infertility. And we both discussed really early on, we both had strong desires to be parents, to have children. And prior to that point in time in my life, through my previous life experience, you know, I had been in previous loving, caring, long-term relationships, but for various personal circumstances, you know, children could never have been a reality for me prior to this point in time. So here I found myself mid-30s, and my wife a little bit younger, with this window of opportunity to grasp the concept or grasp the chance to become parents. Because we were both sort of mid-30s, you know, that window of fertility for women was closing, and we decided to take immediate action and pursue the journey immediately. So I did. I had the sperm analysis done, confirmed infertility, and then we arranged appointments with fertility clinic. So my wife had to have genetic screening done to make sure she wasn't a CF carrier before we embarked on that journey. And fortunately for us, she wasn't. So I won't go into the whole history of this of our IVF journey, but I'll just summarize it very quickly. We went through 3 cycles of upregulation and egg collection. I had sperm analysis or sperm extraction done surgically. In our journey, then we went through 6 implants, 3 fresh and 3 frozen implants. Our journey spanned 2 separate IVF clinics. We changed midway, and you know, a lot of trials and tribulations during that journey, including a miscarriage. Both our daughters were born by cesarean. Our youngest daughter, Anya, was born 7 weeks premature, and in fact, she was a twin, and unfortunately, her twin didn't survive, was born stillborn. So there was a lot of, you know, difficulty, personal challenge, personal pain, but at the end, we ended up with 2 lovely, healthy children. And I'm just going to share my screen here, or yeah, sure. Let's see. Okay, and sorry, just bear with me. Here we go. Works better in rehearsal. So, and here we are now, my lovely family. So I feel very blessed and very fortunate, and I'm a very lucky and happy man to be a parent to two wonderful children. So Florence is the eldest and Anya is the youngest, and here they are aged approximately age 7 and 6. And my wonderful wife, Sarah, as well. And she was fantastic through the journey of IVF and through all those tough challenges. So I'll move quickly on to parenting. And, you know, before we started the journey, I had to really, you know, ask myself, you know, what are the considerations I need to think about in terms of becoming a parent? You know, my health status, you know, okay, so I have CF. I was at that age, I was 35 years old. I also had CF related diabetes. But my lung function was relatively stable and you know, reasonable. It wasn't brilliant, but it was reasonable. And, you know, I considered that, okay, I don't know my longevity or my survival, no one does, but I felt that I could embark on this journey and could contribute to family life. So, you know, we started into it, and then we had the challenges of the early infant and the toddler years, and those presented challenges to my health in terms of the treatment, the burden treatment in CF, and, you know, often with changing nappies or bottle feeds and nighttime and so on, you know, all your best intentions for medication adherence, you know, were challenged by having, you know, by having other priorities that were more pressing. So, you know, nebulizer adherence, medication adherence, but also in terms of CF related diabetes, you know, that was also quite challenging in terms of, you know, you might sit down to eat a meal, you've queued up how much carbohydrates you're going to eat, and you take insulin for that accordingly. And then you get disturbed by that meal. You have to go deal with a screaming baby that may have fallen, or they may need a nappy change, or whatever may be the case, and you only get to eat half your meal, but you've taken too much insulin then, essentially. So, you know, your management was challenged, your health management was challenged by you know, family events, and I found that quite a difficult challenge. But all in all, you know, we tried as a family to share the burden of care, even though, you know, it falls disproportionately to the female in that young family stage. But I did try to be as supportive as I could and contribute as best I could to the family. And, you know, exercise and physio were also disrupted dramatically. But I did try, like, I had a little bike trailer, and I used to put the two infants in the trailer and go for a cycle. Or, you know, I had this wheel attachment, take the bike trailer off and turn it into a buggy, and I could go, you know, get my jogs in and run around the block with the two of them. It's, you know, like two peas in a pod with their blankets and their toys and so on. And they used to love that. So there's ways of, you know, getting around some hurdles. And then, you know, some of the impacts I would consider, you know, what does my CF, how does that impact my daughters? You know, what legacy would my CF have on them? So here's my daughter Anya when she was just an infant, and let's ignore the health and safety challenges here when she's sitting on top of the electric fire. I'll in my defense, I did put safety padding on the marble plinth, you know, so she wouldn't bash her head. So here she is, injecting herself with a toy needle, and she's mimicking exactly what I was doing when I was injecting with my insulin, lifting up the shirt, injecting into the belly, you know, and at such a young age, she's doing that. So I don't have the answer what impact my CF has on them. They hear me coughing every day, but, you know, they're almost oblivious to it. It doesn't seem to bother them. You know, only time will tell as they grow up what sort of impact my CF has on them. I hope that I live a long, normal life, or like a long life as possible, and see them grow into adulthood. And they're my hopes and aspirations for being a parent with CF. And my ethos is to give them as much time as I can, while I can, you know, and you know, for their formative years. So that opens up, you know, thoughts and considerations for any parents watching, you know, that maybe one day you may become grandparents as your children with CF grow and, you know, aspire to be parents themselves. So thanks very much.
Thanks, Rory. I just love that picture. It's fabulous. It just tells a story in itself. A lot of really personal insights there, but I think it really helps people make an informed decision about what the road ahead might bring when it comes to the exciting stage of planning a family. I'm going to invite our final speaker in, and then we will be back for questions after that. And our final speaker is Dr. Jennifer Donnelly. And Dr. Donnelly is a consultant in obstetrics and gynecology with special interest in prenatal diagnosis, fetal treatment, and the medical complications of pregnancy. I hope I've done justice to that there. Welcome, and we'll let you take it from there.
Thanks very much. Thanks so much for inviting me today, and thanks to Rory and Jen for their fantastic stories and experiences and sharing them with us. I love the photos, they're so cute. So I'll just share my screen here and get started. So basically, as per the introduction, I'm an obstetrician, maternal fetal medicine specialist working in the Rotunda, and along with two of my other colleagues, I run the maternal medicine antenatal clinic in the Rotunda, and this provides antenatal care for women with a broad range of medical conditions, including CF. Also, I work at the Mater Hospital, and I do a preconception clinic there for women with complex medical disorders. I provide information on contraception and pregnancy planning, as well as providing obstetric advice to pregnant women who are in this HDU and ICU setting. So I've seen women in a range of, with cystic fibrosis, in a range of situations, trying to get pregnant, who are pregnant, planning a future pregnancy. And I'll be talking about pregnancy planning, contraception, the obstetric management of a woman with CF, as well as a little bit about fertility. I'm not going to talk about fertility investigations or male factors, as that's kind of outside of the scope of my expertise. So as Rory said, that in this Independent Living in Cystic Fibrosis report published in 2016 or in 2017, that at that stage, 26% of survey respondents were parents, but that question had not been asked when the survey was done 20 years ago. And that was just so striking. And I suppose that is given that the first recorded pregnancy of a woman with CF was only 30 years before that first pregnancy. So it just shows how far, to be talking of parents and grandparents when the first recorded pregnancy was only 60 years ago, it really seems quite a remarkable change. So the National Clinical Programme for Cystic Fibrosis Model of Care was launched in September 2019, a couple of years after the establishment of the National Clinical Programme. And in that, it was recommended that pregnant women with cystic fibrosis should attend an obstetric hospital that has experience of looking after women with cystic fibrosis and formal links with a designated cystic fibrosis centre. In Dublin, the 3 maternity hospitals are standalone and they aren't on the sites of cystic fibrosis centres. And this is not the case in Galway and Cork, where they are on the same site. But although there are formal links between hospitals, the linked services have really grown organically, really, rather than in a formal way, to respond to the needs of women with CF who become pregnant, and they're increasing over time. And I'd hope that in the future iteration of the document, input from obstetricians, midwives, and parents and families with CF can help maybe formalise models of care and advocate for fertility services as well as services for pregnancy, because I think that fertility service is certainly something that is lacking. If we look at the number of women who have become pregnant, who have cystic fibrosis over the last number of years, these are figures from the US Cystic Fibrosis and Pregnancy Register. And in 1998, there were 140 pregnancies, which doubled to 280 in 2018. Now, these are only pregnancies that were registered, and we know that numbers of this are much higher. But this is very much looking at the kind of a medical model of care, and that is the case in the European guidelines of CF, and in this, pregnancy is listed as a medical complication. And although pregnancy can pose challenges, I don't believe that it should be viewed as a complication. It has to be managed, but it's a key psychosocial transition point. It requires increased support for fertility-related issues as well as parenthood, as has been discussed throughout this talk. The desire to reproduce is a fundamental component of life for many people, and as a clinician, which I am, that the onus really on us is to provide accurate and appropriate information for people who are planning pregnancy. And as the evidence base grows and the safety for women grows, we need to support people through their pregnancies and not treat it as a complication, but indeed as a part of life. Multiple studies have shown that people with CF, women with CF, wish to have children at rates that are similar to women without cystic fibrosis, and in some studies, perhaps even at a higher rate and potentially at an early age. Most women with cystic fibrosis can become pregnant, and only a small number of women who have significant complications such as pulmonary hypertension and right heart failure should be advised to avoid against pregnancy. I think it's really important to state here that just because somebody's been told that they shouldn't get pregnant doesn't mean that they can't become pregnant. So therefore, it's really important to think about contraception from an early stage, and that conversation really should begin in adolescence. So what type of contraception is appropriate for women with CF? This is a study from last year from the journal Contraception, which showed that women with CF use pretty much the same type of contraception as women who don't have CF. And you can see the spread of COCP being the combined oral contraceptive pill and LARC being long-acting reversible contraceptive methods such as the bar and the coil. Of the women in this study who became pregnant, at least half of them reported having one unintended pregnancy. So it shows that, regardless of planning or not planning, many women will become pregnant without planning to become pregnant. So it's important that the conversation about reproductive health takes place throughout the reproductive life, not just when someone decides that they might want to become pregnant. The Faculty of Sexual and Reproductive Health in the UK have an excellent free online resource for contraception with women with various medical conditions. And they state that to be effective, contraception must be used continuously and correctly. And effective and correct use is directly related to its acceptability. If someone finds something easy to take or easy to use, they're going to use it better. This is kind of a very busy slide with all the different types of contraceptives that are available. And I've highlighted the most effective ones in red. And so that's the bar or the subdermal progesterone implant and intrauterine contraceptive devices. So we can see that they're extremely effective, over 99% effective. And this is over time, over years, over 3 to 10 years, as opposed to, say, for example, male condoms or the withdrawal method. Those are only about 82% or 78% effective per each encounter. So you can tell that over a long period of time that it's highly likely that an unplanned or unintended pregnancy may take place if these methods are being used. So while each method is reasonably good or very good, it isn't 100%. And you can't just be a little bit pregnant, you're either pregnant or not. So it's really important, particularly if you're taking medications, to consider using a very effective method of contraception. And again, that's endorsed by the FSRH. So to use a method of contraception to reduce the likelihood of unintended pregnancy. So with women with cystic fibrosis, if it's appropriate, should consider long-acting reversible contraceptives. And these are very safe methods. They can be used in women who have never become pregnant before. They aren't associated with an increased risk of infection. That was often something that people maybe put people off. But many women, teenagers and young women would use long-acting coils for contraception pre-pregnancy, and they can easily be taken out. So now with the advent of CFTR modulators, does this have an effect on contraception? And what are the contraceptive options available? So most of them, ivacaftor, tezacaftor, and elzacaftor, don't appear to have any effect on hormonal contraceptives. So that really means that if it's appropriate otherwise medically, then any option is open. However, lumacaftor is a strong inducer of this enzyme called cytochrome P453A, and it's in Orkambi, and so there it can decrease serum concentration of estrogen, which is in the combined oral contraceptive pill, and therefore it can reduce the effectiveness of the combined oral contraceptive pill. So for women on Orkambi, it's not an effective method of contraception. Also, in addition, it does appear that this interaction increases the incidence of irregular menstrual bleeding and heavy periods. So it's just something to consider. So Rory actually touched on it in his talk, talking about genetic counselling for his partner prior to becoming pregnant, because obviously you don't need me to tell you that children born to mothers with cystic fibrosis are obligate carriers, and also that if a partner is a carrier, risk of having a child with cystic fibrosis is about 50%. So partners should and can be offered screening. But unfortunately, as I'm sure you well know, that timely access to genetic counselling is limited in Ireland due to chronic underfunding and investment. That's despite the explosion in genetic information that's available to people now, and that impact and the impact that it may have on treatment decisions. In addition, how to interpret this information, this genetic information, and how to make decisions around family formation in relation to this takes time. Some people will have this in advance and will seek it out. Some people may not be as familiar with it. Some couples who then know their status may choose to have prenatal diagnosis testing during pregnancy. Some people may decide to try and get testing prior to pregnancy through IVF, and some may decide to wait until after their baby is born prior to having testing. And this is an individual decision that really requires, thought and discussion and counselling in many couples, or certainly between couples themselves, before making any decisions to try and work out what is the best route for them to take. So pregnancy rates in the US and the UK in women with CF are probably just about 40 per thousand per year, compared to 80 per thousand per year in the general population. Now, this is all women of reproductive age, so it may be that not all people are planning a pregnancy, and overall, although 2 to 4% of people with CF estimation to becoming pregnant per year, it maybe seems a small number. In fact, most people aren't thinking about getting pregnant all the time, and most people won't be having many pregnancies. So this is a very reasonable number. And in a recent study of people attempting to become pregnant, about 40% of women with cystic fibrosis are attempting pregnancy. Subfertility or infertility, difficulties in getting pregnant, does seem to be higher though in women with cystic fibrosis. But again, it's not a given, and many women may conceive without any difficulties. So again, if you don't want to get pregnant, do use contraception. But if you do want to get pregnant, then and you're not getting pregnant, then further investigations are recommended, and indeed but may be required. There may be issues that are completely unrelated to cystic fibrosis, such as tubal factors, previous infection, endometriosis, male factor non-CF related, or other hormonal factors such as polycystic ovarian syndrome. Specific to cystic fibrosis, there can be hypothalamic suppression of hormones within the brain that can have an impact on ovulation. Also, disease-related stress. If someone is unwell for a period of time, is in hospital, this may have an impact on their ovulation. Also, defects in the CFTR gene may cause problems with cervical epithelium, and which is the skin of the cervix and the mucus production cells, as well as the lining of the womb, and this may have an impact on fertility as well. Some recent studies have suggested that women with CF may have a lower ovarian reserve, although the reasons for this aren't clear, and this is not necessarily across the board. So again, back to this slide about planning, but this kind of time highlighting about planning and considering about medication. Often when I see women, they may already be pregnant, but many of you listening here, maybe people with cystic fibrosis or healthcare workers looking after people with cystic fibrosis. And so there's always a possibility of discussing pregnancy and thinking about contraception and planning what would you do, particularly if there's going to be a change to the medication. This image is taken from the Embrace report, which is a report published every year in the UK and Ireland, which is a confidential inquiry into maternal death. But this highlights things that we need to focus on in order to improve outcomes for women in pregnancy, not just for deaths, but for general health in women, particularly with medical disorders. And they really have highlighted the need for forward planning. Women are naturally concerned maybe about effects that medications may have, but stopping or switching abruptly of particular medications may be problematic for maternal well-being, and that's why having a conversation with your cystic fibrosis team about the medications that you're on, their suitability for pregnancy, antibiotics that you might need, doing this in advance, or doing this over many years, so that when the time comes for you thinking about getting pregnant, or if it was unintended, that the medications that you're on are the best ones for you in that situation. When making a pregnancy risk assessment, pre-pregnancy risk assessment, it's always important to base that assessment and base likely outcomes on an individual's current status. And this status may change over time. So you may have discussed pregnancy a couple of years ago, but things may have changed, medications may have changed, lung function may have changed, diabetes may have changed over time. So, over time, things change, benefits and risks change. Benefits and risks of certain medications may change based on people's current status and how they are at the time. Baseline pulmonary function is one of the most important predictors for pregnancy outcome in women with CF. Good diabetes control is also very important throughout pregnancy to optimize neonatal or infant outcome. Poor control of diabetes in pregnancy can be linked to large babies or small babies, as well as labor complications and low blood sugars in the baby after they're born, even despite rigorous control. And I think diabetes can sometimes, or can often, be difficult to control outside of pregnancy, and in pregnancy it can be even more difficult to control, which is very frustrating for people often. This is often due to the nutritional demands of pregnancy, which increase by up to 300 calories per day, and planning on how to deal with that. These increased requirements may be there from the first trimester. Also, there does appear to be an increased rate of preterm delivery in women with cystic fibrosis. And it's hard to imagine the impact of a preterm delivery prior to having had a child that's preterm. But even though it does appear to be increased with women in CF, most of the preterm deliveries are after 34 weeks, which is usually associated with a much better neonatal outcome. In terms of medication, in the Rotunda, we've recently set up the Irish Medicines of Pregnancy Service, which provides, its ultimate aim is to support women and their families to get information on safe, effective use of medicines and pregnancies. At the moment, it's a local service for people in the Rotunda, but Beaumont and the Mater, but we have given advice to people around the country, and hopefully as our staff will increase, and information leaflets that we have produced will increase, and we can share them with others as that evolves. I suppose what information is available in relation to CFTR modulators and outcomes of pregnancy. A lot of early data has come from women who previously had been unable to get pregnant, assumed they couldn't get pregnant, and became pregnant in ivacaftor trials. And in fact, the outcomes of that were very good for both the fetus and the mother. This paper, published last year by Nash et al., is a survey of clinicians around the world, in the UK, Australia, and the US, and identified 64 pregnancies in 61 women who were on CFTR modulators during pregnancy. And although this group is small, there were no reported modulator complications in exposed infants, although the length of time in gestation is varied. Case reports and this study seem to support that there does not appear to be teratogenesis or malformations associated with the use of this medication, although obviously numbers are small. But it also highlights the need for individual assessment for women who are on treatment ideally before they become pregnant. But again, because lung function can deteriorate, or because lung function can deteriorate if medication is stopped, it's important not to stop medication abruptly if you become pregnant, because that may ultimately have an impact on pregnancy. So if you are on these medications and become pregnant, it's important to keep taking them and contact your team as soon as possible to have a consultation about continuance and modification of any medications that are required. So this study basically compares women who have been pregnant with women who've never been pregnant who have cystic fibrosis, published about a couple of years ago by the American Thoracic Society. And it matched, so women who were pregnant with 10 women with cystic fibrosis who had never become pregnant. And when they looked at them over a period of time, they showed that there was no convincing evidence that pregnancy was associated with an increased mortality, which is really good to hear, or a long-term decrease in FEV1, other than that would be expected from the disease itself. So pregnancy and motherhood don't appear to accelerate disease progression, but they do. It does appear to lead to an increased amount of illness-related visits, an increased amount of pulmonary or infective exacerbations, and a decrease in some domains of quality of life during the time of the pregnancy. And these differences presumably reflect the impact of the emotional and physical challenge of early motherhood and on disease management that both Rory and Jen very eloquently described in their talks. This table looks at the outcomes, the obstetric outcomes of women with cystic fibrosis in the UK, and it looks at 63 pregnancies in total. It shows overall that the rate of miscarriage doesn't seem to be increased. There was no fetal abnormalities in one group, and in all group of pregnancies in total, there was one baby who was sadly stillborn, and one woman who had a termination of pregnancy at 18 weeks due to severe illness. Other than that, all babies survived and all mothers survived through the pregnancy. What was noted in this study and others is that women with lower FEV1s going into pregnancy had increased rates of preterm delivery, increased rates of cesarean section, and there were some deaths in this group over time. But again, as per the previous study, that does seem to be related to status prior to becoming pregnant rather than to pregnancy itself. Overall, death related to pregnancy and cystic fibrosis is small, and although this is Irish data published recently, showed 2 women with cystic fibrosis who died during or shortly after pregnancy in a 3-year period. However, I think looking at numbers over time, over a longer period of time, and looking at the UK data, it doesn't appear that overall that this is significantly increased, although obviously any deaths are always tragic when they occur. But again, with this report, it brings recommendations, and it does suggest that women with medical disorders in pregnancy, regardless of what it is, should have access to a coordinated multidisciplinary clinic, both obstetrics and medicine. Again, as Jen said, avoiding the need, if possible, to attend multiple appointments at the same time, and for poor communication, and to reduce the likelihood of poor communication between specialists that are coordinating care. So who are the multidisciplinary team? Well, they're a combination of people, pre-existing cystic fibrosis team, a maternal medicine obstetric service with obstetricians, midwives, obviously the pregnant woman herself, her family, obstetric anesthesia and neonatology are ones that you may not be familiar with compared to people that you're familiar with more regularly with cystic fibrosis care, such as CF medical specialists, nurses, physios, dietitians, social workers, psychologists, pharmacists. And again, in the obstetric services, there may be other dietitians, social workers, psychologists, and physios that can link in with a more obstetric perspective. Where I work, by way of explanation, is spread across a number of different sites, as I said at the beginning of the talk. And this is really developed organically. And, there's a role for each kind of low risk, complications, higher risk, place of admission. Where the admission takes place really depends on, I suppose, the gestation, if that's required during pregnancy. But if there is an admission, both either to a maternity hospital or to a general hospital, that communication kind of continues so that there's adequate monitoring of both baby and of the mum throughout the pregnancy. And this is really why communication is key, not just communication, but also coordination. There's lots of people with lots of specialized knowledge, and we have to make sure that we all know what the others don't know, and not to assume anything, that we're all potentially experts in our own area, but we all have gaps in our knowledge. And so sharing our knowledge is so important, and making sure that plans are clarified, that a woman feels very engaged in her care and knows who to call if she has a problem, knows where to go, doesn't feel confused about who she needs to ask about, and is there someone that she can go to and say, right, you need to talk to that person or this person. And so that's, I suppose, one of the roles of the obstetric team in the management of pregnancy. One of the ways to facilitate this is a multidisciplinary team meeting. We have one set up that runs about every 4 to 6 weeks. And over the last 4 years, we've discussed a wide variety of cases, and in the respiratory, about 16. And that would include a number of women with cystic fibrosis and a number of women post-transplant who have maybe had a pre-pregnancy discussion, or a couple of people who have become pregnant during that time. There are just some emails once you're referred to the system to access and to make sure that everyone knows about the coordination. I think Jen really well described how things that she really wasn't expecting changed during the course of her pregnancy. The physio lung clearance, also the limitations that can take place with hyperemesis and how that can have an impact on your nutrition. Also incontinence with coughing, with the increased incontinence can increase anyway during pregnancy. The volume, the baby sitting on the bladder, getting bigger, pressing down, and that coupled with coughing and physio can be quite significant for some women. Diabetes management, as I mentioned, have changed. Some people may have poor vascular access if they've had many lines or things before, and so planning that. Is there a need for kind of more long-term vascular access during pregnancy, and also antenatal education that's focused on the needs of women. Given COVID, the vaccine, is that appropriate? What are the positives and negatives of that? And also even during pregnancy, to think about contraception, to plan contraception for afterwards, to be thinking about, what are the methods that are appropriate and available, what antibiotics may be used and can be used. I suppose a little bit just about complications of pregnancy. Pulmonary hemorrhage is rare, but medications that are used in advance of that or are used should be planned in advance, such as tranexamic acid. It is safe, but in an emergency setting, the priority is to stabilize the mother. By stabilizing the mother, you're helping the baby, and so that really has to be the priority. One thing that has come across is the use of ultrasound. So this is a very bad picture of a very bad ultrasound that I did on a woman who'd had a pneumothorax in pregnancy, and I couldn't work out why I couldn't get good views of the baby. This is very distressing, obviously, for the mum who was in hospital, and we finally worked out that it was because she had a lot of air in her skin, which was preventing the ultrasound beams from getting in. And finally, as soon as and although we were able to confirm that the baby was doing well, we couldn't get very much detail. As soon as the chest drain was removed, we get a really clear picture, which was great. And it was something that we hadn't come across before. So it's all a learning curve. And she had given me her permission to share these images, as has this woman. So a lot of people ask the question, do I need to have a cesarean section? And certainly not. In most cases, if someone needs to have a cesarean section, it would be for obstetric indications, like, for example, twins, or a breech presentation, or a placental complication, or what anyone else might need a cesarean section for. I did mention that a cesarean section may be higher in preterm births, and women with cystic fibrosis may have a higher incidence of preterm birth, and so that may be necessary, but it's certainly not a given. Again, someone may opt for a cesarean section, but with an abdominal wound, recovery from that, clearing secretions, can be difficult. Anesthetic planning is very important in terms of pain relief afterwards, and if someone is planning to breastfeed, that they modify that they increase their calories to support them to do that. And particularly if you have a low BMI with breastfeeding, it's really, really important to make sure that calories are good. Motherhood and postnatal is a challenge for any person, and mental health support is a big, big challenge. Again, Rory touched on a lot of those about the challenges of that. And so mental health support, both with your CF team and perinatal, is important. And thankfully, there has been some investment in those services over the last number of years. And then going back to contraception again. I have a couple of slides about pregnancy and lung transplantation, but I think given the time limitations, I'll just kind of speed through those. And if anyone has any questions, we can always answer them in the Q&A. So I suppose in summary, effective contraception until you're planning a pregnancy. You don't need to be, not wanting to become pregnant to use contraception, and use the contraceptive method that is the most effective. For women with cystic fibrosis, successful pregnancy rates continue to rise. Despite fertility issues, many women will get pregnant without any fertility issues. Fetal and maternal outcomes have improved dramatically over the last number of years. And someone with well-preserved lung function, who's got a good nutritional status, well-controlled diabetes, their long-term maternal outcomes appear to be equal to those who haven't become pregnant, which is great news. Pregnancy planning, and I can't say enough about contraception, again, are key. Medication review prior to pregnancy and kind of throughout life, with the possibility of pregnancy in mind. I think as clinicians, we should continue to advocate for genetic counselling for women with cystic fibrosis and their partners, to allow those conversations to take place well in advance of ever becoming pregnant, and throughout pregnancy to have a clear multidisciplinary pregnancy and communication plan. So, I mentioned the specialties. These are a number of people who are very key in management of pregnancy for people with cystic fibrosis. I'd like to thank each and every one of them, and thank you all for inviting me today. Thanks.
Thank you so much. That was extremely comprehensive, and I'm delighted we have the time. I'm sorry if you felt rushed at the end.
No. I just wanted to make sure we finished on time.
I think you did extremely well to convey a phenomenal amount of information. And I suppose I'd love to bring back Jen and Rory at this point. Rory, just a question for you, I suppose, in relation to I know you spoke a bit about, your children's observations of you being sick. And I suppose that's something I'm wondering about your partner, about Sarah, and the impact of you being sick on her, or any thoughts on that?
She's been really great, and I think her approach to life is what will be, but Unfortunately, I haven't been very sick with CF. You know, I have required intravenous antibiotics and at very challenging times. So when Anya was born, and in the neonatal intensive care after she was born 7 weeks premature, you know, I was on home intravenous antibiotics at that time. And I remember going in to see her, and I was, you know, masking up and gloves and everything to try, because I didn't want to bring any sort of infection challenge into the neonatal unit. So I was really cautious about that. But, you know, Sarah was in there. She was brilliant. She was with Anya as much as she could. And, you know, she wasn't, at least not outwardly, so concerned about me, but or inwardly, maybe, you know, I don't know, but she's always been brilliant. And I mean, you know, any marriage or relationship, you know, communication is very important, and sharing the workload and so on. But like, you know, fortunately, as I said, I haven't been really sick. Few intravenous antibiotic episodes. The girls haven't actually, they've only seen me when they were infants, and they won't remember that, but only in their living memory, you know, as such, only once on home IVs or in patient. So I've been lucky that way in terms of health.
Fantastic. I have a feeling that if we let you go, Dr. Donnelly, without you mentioning the transplant scenario, I think we'd probably be inundated with queries. So I suppose, I mean, you had quite a bit of information there that you could dip into, but maybe, I suppose, just something that you would think about, just your thoughts about the complications, or maybe things that people might be thinking it's completely out of the question if they've had a transplant, but you might shed some light on that.
Yeah, I think, I mean, again, this is very, very individualized, and it's very new. And talking to some of the transplant physicians around the country, you know, they have said, like, up until recently in many centers around the world, that it wasn't being recommended. In fact, they're saying, you know, don't get pregnant. But I think that, you know, we kind of know that saying don't get pregnant doesn't always work, and that some people will get pregnant, but also actually that, you know, given the history of solid lung of solid organ transplant, say for example in kidney transplant, has been very successful, and so it is something that is probably going to be seen more and more. I suppose what has come through on the available information is that there does appear to be a slightly increased risk of rejection, potentially pregnancy related, with lung transplantation compared to other solid lung transplants, which is why that it is not the same as kidney transplant. But there is, you know, there again, I think it's one of the situations whereby the medications that women are on before becoming or attempting pregnancy are so critical. The other issues that they may have, you know, other kind of chronic infections, that those are optimized, because if they are thinking of becoming pregnant, and what medications are on, because there may be some medications that are absolutely, I mean, you can't become pregnant. And there are many medications that we can become pregnant on if you're immunosuppressed, but there are certain ones, for example, mycophenolate, that you should not become pregnant on, because they are dangerous to the developing baby. And so the kind of general guidance about that is not to generalize, is that each person should have their own circumstances taken into account, what their general health is, what their graft function is, at least wait 1 to 2 years minimum after transplant with no episodes of rejection, that there's no other ongoing evidence of chronic infection. And there are other complications that may be there, for example, blood pressure, and people who are hypertensive are at increased risk of complications. So if that's there, that may also have an impact. If there's a renal disease or kidney disease, that can also have an impact on the outcome of pregnancy, regardless of lung transplantation or not. So somebody maybe who has got significant kidney disease and high blood pressure and a lung transplant, that may be a setting where you might really say, look, this is very complex, and looking at other methods of family formation, such as surrogacy. But, you know, there have been women in Ireland with lung transplants who've become pregnant, had successful pregnancies, but which is great. But it's just, I think, individualizing, talking to your team at an early stage and planning it, looking at the possibilities, because sometimes there are alterations in medications that can be made that won't have an impact on the long-term outcome. And so those should be done ideally in advance of pregnancy.
That's fantastic. Thank you. I suppose it made me think about a question for you, Rory, in terms of, did you consider alternatives to IVF? And I suppose somebody in the post-transplant situation, when they do their due diligence and their forward planning, they may begin to explore other avenues.
Yeah, absolutely. I mean, we went through several rounds of IVF, and at each failure or each hurdle that you hit with IVF, you reassess, you know, do we go again? What should we do different? Are there alternatives? So certainly maybe in post-transplant pregnancy, cases you can consider surrogacy, or in females with CF who are having infertility trouble, you can maybe consider maybe egg donor, and in males or couples where the male is the person with CF, you can consider sperm donor as well. So, and in couples, you can also consider adoption and look at those avenues. So, if you really desire to be a parent, or look at all the options as the challenges present to you during an IVF journey.
Thanks, Rory. That is, I suppose that the positive thing is that there is so many different options now to consider. And it seems to be very individualized, and the key word that crops up again and again is have that conversation and do a bit of planning. One final comment just came in saying that somebody was there, they were post-transplant with 2 children, and pre-pregnancy planning is absolutely essential, that they were 15 years post-transplant having their first baby girl. So it's a lovely positive note to finish on. Unfortunately, we've run a little bit over time, and I'd just like to thank you all for just your openness and sharing your wisdom and your experience with us. I think if people have further questions or want to continue the conversation, they could have a look back at this presentation. It will be up on the website in the coming weeks, and you can just review it and just reflect on the information and take what you need from it in your own time. Thank you so much, Dr. Donnelly. Thanks, Jen.
Thank you.
And thanks, Rory.